We are very excited to have an incredible pediatric neurosurgeon and clinician scientist with us today, Dr. Bill Whitehead. Dr. Whitehead is professor of pediatric neurosurgery with Baylor College of Medicine and director pediatric neurosurgery fellowship program at Texas Children's Hospital in Houston. We'll be discussing the impactful work of the Hydrocephalus Clinical Research Network, or HCRN. Dr. Whitehead has recently assumed the reins as chair of this network. We should acknowledge the many years of outstanding leadership from Dr. John Kessel in the founding and oversight of the HCRN since the beginning, and that John will continue to remain involved. But Bill, let's get started. Tell us how you came to be a doctor and why did you specialize in pediatric neurosurgery?
Um, well, thank you. I just want to say thanks first for asking me to do this, to talk about the HCRN, which is really my clinical focus right now, my research focus. It's been great working with John. I knew him when I was a resident. Taught me a lot about pediatric neurosurgery, but also clinical epidemiology and answering research questions. And he started this network back in 2008, and I was one of the early members. We've learned a lot since then. It's a little bit sad for me to see him stepping down. None of us wanted that. It's great that he's going to stay involved, at least for a few more years as we finish one of the studies that I'm sure we'll talk about. So to answer your question, I decided to be a doctor after I finished college. I was working in a research lab doing molecular biology, studying human development and a mouse model, and thinking I was going to go to graduate school to do basic science research. One of the things I was asked to do while I was in the lab was to orient a pediatric neurologist who was doing some basic science research for her patients. Her name was Dr. Ment, Laura Ment. And she got to know me, asked me to come to her clinic. I shadowed her, saw her take care of patients. And after a few visits, I decided to go to medical school, and then through several twists and turns, got into pediatric neurosurgery, and very happy that I did.
That's wonderful. Well, we're grateful that you did make that decision for sure. So let's get into the HCRN. How does the work of the HCRN directly improve the lives of patients and families? And how do you ensure that their voices are heard in the research process?
So that is really the mission of the HCRN. We do this to improve patient outcomes and improve the lives of children with hydrocephalus, and we focus on pediatric patients. And we do that through multi-centered collaborative research. Hydrocephalus is the most common thing that pediatric neurosurgeons treat, but it's still a rare disease. And when you're studying it at your center alone, there's not that many patients. So it's hard to pick up small trends and small risk factors. You need a lot of patience. And so the HCRN was started out as 4 centers. We're now 14 centers. We have a very large registry where we collect data on all the patients who are diagnosed with hydrocephalus, whether they get a shunt or a third ventriculostomy. The number of patients in the registry now is over 10,000. So we have a lot of data to look at, to look for risk factors for treatment failures, to look to see if certain valves or equipment or techniques or surgeries have better outcomes. You can't always see that when you're looking at 100 patients, but when you're looking at 10,000 patients, you can start to see trends and kind of push things in the right direction. A few years ago, the HCRN published a study looking at shunt failure rates and compared it to outcomes in the 90s to outcomes in the 2010s, teens. And the actual rate of shunt failure has gone down. It used to be around 40% in the first year, and now um, it's closer to 30%. So we weren't quite sure what the difference was. There are probably many factors involved, but one of the things I think that we're doing is just continuing to push the needle in the right direction so that shunts last longer.
That's really good news. I'm sure the folks who are listening are going to be happy to hear that new statistic. That's wonderful. So, the HCRN is currently involved in a really significant NIH grant to study ETV CPC versus shunting through a randomized process. What are the primary goals of this study, and can you tell us a little bit about some of the challenges of trying to conduct a study like this?
Yeah, this is one of our bigger studies. We've been enrolling patients now for over 3 years. We did a lot of background work to create the protocol to do it. This is a prospective study, so we enroll patients, and then the study compares the two most common treatments for infant hydrocephalus treatment. So shunting is one, and the other treatment is third ventriculostomy with choroid plexus coagulation, which was really popularized by Dr. Ben Wharf when he spent several years in Uganda. So we spent a lot of time learning that technique, bringing it back to North American populations with pediatric hydrocephalus, which I will say is different from sub-Saharan African hydrocephalus. Hydrocephalus is also difficult to study because it's a heterogeneous disease. There's lots of different causes, either congenital or acquired. So certain treatments may work better in one group versus the other. So the trial is randomizing patients between the two groups, and the primary outcome is cognitive function. We know that shunts have a high failure rate in the long term. It's an implant. The body can't renew it. Slowly but surely, the body will start to wall it off with scar tissue, and the holes that allow fluid to drain get blocked, or they get infected, and then they have to be replaced. And this can happen at random times and be very disruptive. The endoscopic third ventriculostomy treatment with choroid plexus coagulation is an alternative to that does not involve an implant. The problem with that procedure is it has a very high failure rate in the first 6 months. The failure rate is 50%. So it's a surgery that has a 50% failure rate in the first 6 months, which is not very good. It's one of the highest failure rates. But in the long term, if you make it 6 months, the failure rate is very low, only about 5%. So if you're in that group where it works, you don't have to worry about an implant. You have a much lower failure rate. And so families might choose that. I don't know which treatment is better. I think both have advantages and disadvantages, and it sort of depends on patient factors, how close you are to pediatric neurosurgery, how willing you are to go through multiple procedures, because every surgery has risk. One of the things that the main thing that we're looking at in this study is the cognitive outcome, because families have told us as we were designing the study that they're willing to accept the risk of a procedure with a high failure rate to avoid the implant. So that's the ETV procedure, as long as the cognitive outcome is the same down the road. So I don't want my child to have lower IQ, or less, or a lower cognitive function if the procedure does that. So if the cognitive functions are the same, we're willing to take that risk. Every family is different. But with this study, we'll be able to tell them whether or not there's a difference in cognitive outcomes at a year, at 3 years, and at 5 years. And then families can decide which one is better. As far as challenges, one of the biggest challenges is recruitment and enrollment. Most people want to make the decision for their child based on what I just reviewed. To do this study correctly and to get the truest answer, patients who are eligible for both procedures that meet all the criteria for the study have to be randomized, which means the family doesn't get to know which surgery they're getting before the procedure, and neither does the surgeon. So you go into the operating room, you get general anesthesia, and then after induction, patients are randomized to one procedure or the other. And then at the end of the surgery, the family knows which one was done, and then we follow them for over time to see what their cognitive outcomes are. And a lot of people aren't willing to make that leap, which is which is which is fine. Research is voluntary. The most important thing that we do is we give people the option of doing that. And along with the study comes some advantages. You get stricter follow-up. You get neuropsychological testing that normally isn't done. So there are advantages to being in studies, but it's a process. You have to do a lot more counseling. You have to really explain to patients why we're doing the study, and we do a lot of work in the beginning to make sure that patients who are eligible are safe for both treatment arms.
Very important study. I can't imagine how difficult that would be for a parent to make that decision. It has to be just so heart-wrenching to have to make that decision, but we need folks to make that decision sometimes. How is the enrollment? How many patients are you trying to get, and how close are you?
So we've enrolled about 120 patients. We need about 185. And once that last patient's enrolled, we need a year of follow-up with this detailed neuropsychological testing.
Yeah, that will be so significant to see those results. And even in the community research priorities work that we did at HA, cognitive outcomes were very important to the hydrocephalus community, living with hydrocephalus, how to live better with hydrocephalus, and less invasive outcomes. All of those things are really important. So this study will be critical for the future.
And I give HA a lot of credit for that shift. Surgeons tend to focus on outcomes like infection and failure. But we know now through through working with groups like HA and patients that these other neuropsychological quality of life outcomes are just as important, if not more important.
Yeah, absolutely. Well, let's talk about another study that has been completed. You are the principal investigator on a study funded by the Patient-Centered Outcomes Research Institute, or PCORI, to examine the best entry site for shunting patients. Why does this type of study matter? And tell us what you discovered.
So this is another example of trying to push the needle in the right direction to get better outcomes. And it was a study comparing two different techniques for shunt insertion in pediatric patients. Surgeons either place the catheter that goes into the brain from an entry site on top of the head or in back of the head. And this has sort of been a debate among surgeons since shunts came into existence. And there's advantages and disadvantages of one versus the other. And I won't go into all those details, but there was data in the literature both ways saying the top is better from one center. And then another center said, no, it's the back. The back is better. And this is the data. And those studies are another example of single center institutions with not a lot of power to detect a difference. I got interested in this question through a back door because I was more interested in where we put the catheter in the brain. So we did a large retrospective study with over 800 patients, all pediatric, and we looked at where the catheter was on the scan to see if you put it in the front of the ventricle, if that shunt lasted longer than if you put it in the back. And so we did that study. We learned that it didn't matter as long as the catheter was in the ventricle, the survival was the same. But we did see a trend towards catheters on top of the head having longer survival than catheters in the back of the head. So that was interesting and seemed to be significant. It seemed like survival rates were 10% better at 1 year if you put it on top of the head. But it was retrospective. It wasn't a great methodology to answer the question. And in order to convince surgeons to change their practice, you really have to do prospective study and randomize patients like I was discussing before. So we did that. And we looked at quality of life measures. We looked at shunt failure rates. And we found that both entry sites had the same failure rate. So they're the same. There's no difference. And that's it's a negative study. But negative studies are important because it answers the question, and then you can move on and study other things. Surgeons should use the entry site, whichever one they're most comfortable with was the conclusion of the study. And now we've moved on to other things.
Yeah, very important for medical practice. The HCRN has 14 centers in the United States and Canada, and represents about 30 investigators in total. That may keep changing. But how does a group like this make decisions on what to study?
We have a process for doing that. That's developed as we've grown. When we initially started, there were only 4 sites. Now there's 14, and we've grown in response to trying to do bigger studies. But there's a committee in the HCRN that looks at study questions. We're a question-driven group. In other words, we do research based on the desire to answer a question to improve the lives of kids with hydrocephalus. So investigators can submit questions and discuss it at our meetings. Eventually, the committee chairs will make a decision about whether or not the study should be done. That process involves a lot of questions and answers and revisions in order to get it to, I would say, a very high standard, so that in the end, we have an answer and not more questions. So a lot of the studies are investigator driven. Sometimes people come to us from other centers with ideas, and they'll work with someone in the HRN to do the study. We've done a couple of studies that way. Occasionally industry will approach us with ideas and things that they want us to test. But everything goes through this process and vetting. And then in the end, we have a protocol, and then we'll do the study. Sometimes it's obvious that the study will need funding, and we'll get it to the point where we want to do it, and then we'll seek funding either through PCORI or the NIH or organizations like HA.
Sounds like a really good process. With 10,000 records, I imagine some of the studies can be retrospective, looking at the registry. Does that happen often?
That is more than half of our studies. Now that the registry has matured and we have years of follow-up on these patients, a lot of the questions start with retrospective reviews. That can guide you towards a prospective study. And retrospective studies are not as strong, they're not as good of an answer to research questions as a prospective study generally. But you have to start with that so you can plan your prospective studies, because when you do a prospective study, you want everything worked out in as much detail as possible so that in the end you have a valid answer. And so a lot of the things like the studies, the ETV CPC study was based on about 3 retrospective studies that we did in the HCRN. Entry site, again, three or four studies looking back at data. And we use that to plan the prospective study. And then both of those trials were funded by NIH and PCORI.
Where do you think the growth opportunities are for the HCRN? More centers, expanded areas of study, or testing new therapies and devices in hydrocephalus, or maybe all of the above?
So I think, one of the biggest things we've done is we've created this infrastructure to do studies. And that's easy to say, but hard to do. getting several pediatric neurosurgeons to collaborate, meet regularly, and then do the day-to-day tasks that are required to do this kind of research is difficult. So in terms of growth, I think the HCRN should add centers based on study questions. For example, if we're interested, we're very interested right now in the different ways that patients with hydrocephalus due to prematurity are treated. There's a lot of variation right now in early management of those patients. We're very interested in the timing of intervention for those patients. And we're thinking about doing a study that will require about 200 patients. Prospective studies are nice, and they're the best way to answer the question, but they can't take 10 years to do. They have to be done relatively quickly, and I would say that time frame for accrual should be somewhere between 2 and 3 years. So once you've planned all of the things in the protocol, you have to identify centers that can accrue patients, and then add centers so that you can meet a deadline of 2 to 3 years. And usually there's at least a year of follow-up to get the outcome. So I think our growth should be, right now we have a lot of centers, we have a lot of data in the registry. I don't think we need to grow from that standpoint. But when new studies are proposed and funded, we need to get them done quickly. I also think there's potential to work with industry more. We haven't done that in the past. A lot of times wait for industry to develop their product or their diagnostic test, and then we'll test it. That's been a good strategy. But we could do things earlier and rely on funding from industry to do studies. That's something that we're slowly moving towards. The thing that we want to avoid the most is introducing bias into our study design and our reporting. Industry, for good reason, gets very invested in what they're doing, and they want to see a positive result. And that can introduce bias. So we have to be very careful about study design and who controls the data, who does the analysis, and who does the reporting. We'll be the first to champion a new product or a new test that works. But if something is harmful or is the same as what we're already doing, we want to say that just as loudly. And so we have to, I think there's potential for growth in that area because these studies are expensive and we need funding, and industry is a way to do that, but it has to be done in the right way.
Thank you. What's the HCRNQ? And I know this is more recent in the development of the HCRN, and it does engage other hospitals and investigators. And so how does it help patients in medical practice?
So HCRNQ was another idea from John Kessel. And it's the Q stands for quality. And it's a way for us to monitor and see how other centers implement what we know is beneficial. The best example is the shunt infection prevention protocol. That was one of the early studies in the HCRN. We found that there was a lot of variation in how shunt operations were done. It was variation in the way that we tried to prevent infection. So the use of antibiotics, the type of prep. There's a lot of different things that surgeons were doing to try to prevent shunt infections. So one of the first things we did was we came up with a protocol that we could all agree on with several steps, and we implemented it at each center. And we found that by following the protocol and being compliant, you could cut your infection rate, in some cases by more than half. And a lot of HCRN centers now are operating with an infection rate of less than 5%. where before the standard rate of infection was somewhere between 8 and 12%. That's been a big improvement. That's another example of trying to make shunts last longer. And infections are significant because, as probably some of the audience knows, it can mean a month in the hospital, which is a lot of time away from school, a lot of time away from work, and a lot of stress. So HCRNQ, so once we learned that, we published it and we want other centers to implement it. The steps in the protocol are important, but just having the protocol is the most important thing. And each center has to adapt the protocol based on the resources they have locally. But implementing a protocol and then following the outcomes is what HCRNQ does. So there's several centers in the HCRNQ. Last time I checked, it was about 30. And they're collecting data about their shunt infection rates and their compliance with the protocol. They're also looking at how they treat patients with hydrocephalus from prematurity and interventricular hemorrhage. The other thing that HCRNQ can do for research is, as I was talking about before, when we need more centers to help with accrual, we look towards the HCRNQ. We look at centers that have the resources to do a bigger study, and then we recruit them to help with the prospective study. And we've done that a little bit with the ETV CPC randomized trial.
It's so encouraging to see the growth of the HCRN over the last decade or more, and just see how many studies are happening and the growth of the network. So it's really wonderful, and hopefully you feel validated in terms of the being part of this. It's hard work, it's extra work to do this on top of a busy surgery schedule, but it's really exciting to see these developments.
It is exactly that. One of the things that keeps me going is the work that we do in the HCRN.
So I want to shift gears just a little bit about something that I didn't know I would be asking you about when we first decided to do this interview. You know, lately we have seen announcements about academic research funded through the NIH and other federal programs being really closely scrutinized. We have witnessed pauses in funding and potential reductions in indirect support to institutions. And I think it's probably important to respond to that issue, but also can you help us understand why indirect expenses are also important and what are they?
So indirect expenses are tacked on to grants. And the best examples are NIH grants and PCORI grants. And those are expenses that institutions, like I work at Baylor College of Medicine, but other universities across the country have expenses that they are responsible for in order to support research. They're expenses that are not directly linked to a specific project, but the university needs those funds to support the research effort. So what does that mean? So there's facilities cost. So we have buildings in our Texas Medical Center that are completely devoted to research. We need lab space, we need utilities, equipment, security, computers at work. All of those things are paid for by the institution, and those indirect cost or facilities cost cover that. Their administrative cost, managing grants, ensuring compliance, regulatory oversight is a big part of what institutions do to make sure that research is being conducted according to protocol and ethically. And protocols have to be reviewed before they're approved. So all those things have cost. might be a misconception that these indirect costs are unnecessary expenses or they're just slush funds that are used by the institution, but they're not. They're essential funds for maintaining the infrastructure to do research. So institutions, and I'm not an expert on this, but institutions negotiate those indirect costs directly with the federal government. If there's waste, then that should be stopped. But I haven't seen evidence of those funds being wasted. But that's what they're for, and that's why they're part of a successful grant application.
That was a great explanation of why indirect expenses are just as important and critical to the lab work and the direct patient work. So if for some reason NIH funding for a certain grant, let's say it's your ETV CPC versus shunting grant, for example, if that funding were to be reduced, even though you already have a contract for it, and those indirect expenses would be reduced to a lower level than can be tolerated by all of the centers, what kinds of impacts would that have on patients to pause or actually have to cancel a research project when you're in the middle of a human clinical trial?
Well, the most obvious answer is it's a tremendous waste to pour resources into a project and not finish it. Um, and if it's an experimental treatment that's working for a patient and then you have to stop it, that can have detrimental effects for the patient. It makes people less likely to participate in research when it's not clear that the research is going to be completed. It makes it difficult for the researchers to collect long-term data and follow-up data. And we want to know the immediate effects of an intervention, but we also want to know how patients are doing 1 year, 2 years, 5 years later. And if you pause a study, you don't get that information. And it slows down advancements. It slows down the search for a cure. It slows down moving the needle a little bit farther in the right direction. So it has a lot of detrimental effects.
Thank you for saying that, because as we work with the hydrocephalus community, which is preemies to the elderly, at any age you can get hydrocephalus. They don't want to wait. They don't want to wait to see advancements in treatments and a potential cure one day. And so it is frustrating for patients and families to imagine that they've enrolled in a research study or even that they're supporting research and to find out that it might be paused or delayed. So I really, really appreciate you explaining how harmful that can be.
Yeah, it makes me nervous, but we keep going.
We do keep going. And we also have a lot of passionate advocates at the Hydrocephalus Association who will speak up on matters of this importance. So one of the last questions I wanted to ask you is, what do you believe is the most important impact of the HCRN to date?
Good question. Um, I think the biggest thing that we've done is established a multi-centered collaborative way to study hydrocephalus. You need numbers, and you need a lot of people working together to ask the right questions. So establishing that infrastructure is really the biggest thing I think we've done, because it allows us to answer so many questions. I can't really point to one study that I mean, there's been several that I think have been impactful, some positive, many negative. But again, negative studies are important. We learn from negative studies. And but getting those answers with statistical power or statistical trueness requires a lot of patience. And I think that's been the biggest success of John's vision for a collaborative network that studies things in real time, actively and prospectively. And my goal as the new chairman is to continue that, to do high quality prospective research on the most important questions in pediatric hydrocephalus.
Thank you so much, Bill, for being willing to talk with me today and really highlight the importance of clinical research in hydrocephalus. We really thank you for your dedication to research to further our knowledge about hydrocephalus and also for the incredible work you do every day, giving life-saving care to kids with hydrocephalus. So thanks for being with us today.
Thank you, Diana, for doing this and for um, just letting people know about the importance of research and for supporting research in the Hydrocephalus Association. Your group and you have supported us for years, financially and at our meetings, and I enjoy your presence there. So thank you.
Thank you. And we will continue to do so. So thank you, Bill, for being with us.